therapeutics and surface modulation. She works as a cornea consultant at Chaitanya Eye Hospital.
Thank you. So first I'll be presenting on ocular therapeutics and surface modulation. As you know, therapy is the mainstay of dry eye disease. So the aim is to restore the homeostasis of the ocular surface. We have to break the vicious cycle of inflammation which is characterized by in the disease. And the tear treatment therapy is classified into tear insufficiency therapy, anti-inflammatory therapy, and there is newer therapeutics. Tear insufficiency management can be tear replacement approach by using artificial tear supplements, biological tear supplements and others. Tear conservation can be by punctal occlusion, moist chamber spectacles and humidifiers. Tear stimulation can be either topical or oral therapy. So whenever we put an eye drop, there is a minimal loss of eye drop through blinking, and it integrates with the tear film. There is evaporation of the eye drop, there is nasolacrimal drainage, tear film breakup time, and also lacrimation also stimulates the drainage, and in effect only a little of the eye drop stays in the surface. So what is an ideal lubricant? It has a rheological property like viscosity. It maintains while there is a blink rate. It maintains the temperature of the ocular surface, maintains the pH of the ocular surface and pH of lubricants. There is a tear clearance rate, and absorption of the lubricant from the ocular surface should be reduced, and it withstands the evaporation rate. Now coming on to artificial tear supplements, we can do aqueous supplementation and lipid supplementation. For aqueous supplementation, we have viscosity enhancing agents, osmotic agents, osmoprotectants, antioxidants, and also a small talk on preservatives. Liquid supplementation can be emulsions, macro, nano and micro emulsions. Now viscosity enhancing agents, they increase the tear film thickness, they promote the tear retention at the ocular surface, protect the ocular surface, improve the goblet cell density, relieve the dry eye symptoms, and it also maintains a physiological corneal thickness. There are various viscosity enhancing agents listed here, popular ones being carboxymethyl cellulose CMC and hyaluronic acid. Osmotic agents, there is raised osmotic osmolarity in dry eye disease. So hypoosmolar hyaluronic acid is given, and it shows a reduction in osmolarity at 8 weeks with significant reduction of interleukins, stabilization of the tear breakup time, and decreased corneal and conjunctival staining. There are osmoprotectants, which are a group of compatible solutes that protect the cells under extreme osmotic stress by balancing the osmotic pressure. So like example like L-carnitine, betaine, trehalose. Trehalose is used clinically. Trehalose protects the corneal cells from desiccation, apoptosis, accelerate their healing and restores and maintain the osmotic balance. It augments autophagy, and this has been shown in various studies that it decreases the tear film cytokine levels and helps to protect the in dry eye disease. Coming on to antioxidants, in dry eye disease there is tear film instability and hyperosmolarity. There is corneal and conjunctival damage and inflammation which releases a reactive oxygen species, and antioxidants like vitamin A, visomitin, selenoprotein P can help in reducing all this. Coming on to preservative, there are multi-dose artificial lubricants typically require a preservative. Now the preservative, we know the various preservative. The famous one is benzalkonium chloride, which has a detergent action and it is deleterious to the ocular surface. So alternative is to use preservative-free unit dose vials, or with eye drops with dispenser that incorporate unidirectional valve that allow multi-dose bottles to be unpreserved. Coming on to lipid supplementation, we can use lipid containing drops which is formulated as emulsions. Macro emulsions has droplets larger than 100 nanometers. Nano emulsions have between 10 to 100 nanometers. Micro emulsions have droplets less than 10 nanometer. Coming on to biological tear substitutes, we can use autologous serum, adult allogenic serum, umbilical cord serum and platelet preparations. So whenever we know there is tear film has antibacterial factors which prevent the desiccation of the cornea. It also has growth factors like epidermal growth factor, fibroblast growth factor which maintains the epithelial health. So whenever there is dry eye, all these factors are blocked and this leads to dry eye symptoms. So we can use surface biomodulation by using biological tear substitutes to bring down the inflammation. Autologous serum, which has various similarities with tears, it maintains the same pH, it has nutrient content and all the growth factors are present. It inhibits the release of inflammatory cytokines and increase the number of goblet cells and mucin expression. Adult allogenic serum can be used in patients with active inflammation, in patients who have a fear of venipuncture, in infants and in chronic anemia. But there is limited clinical data and there is a concern of cross-matching of the blood. Umbilical cord, large quantities of the product may be collected at every delivery. It can be used in debilitated patients with hematological dyscrasia, in infectious diseases, and higher concentration of growth factors as compared to other blood components for topical use. There is platelet preparation. Growth factor content is higher than in plasma or serum, but the preparation is more complex and there is limited clinical data. Now, tear stimulation approach. It can be topical secretagogues or oral secretagogues. Topical secretagogues can be aqueous secretagogues and mucin secretagogues. Aqueous secretagogues, diaquazole tetrasodium, it is a purinergic P2Y2 receptor agonist which stimulates water and mucin secretion. It improves tear film stability in dry eye. Mucin secretagogues, the famous one is ribamipide. It promotes production of mucin-like glycoproteins in human corneal epithelial cells. It increases muc expression through signals involved in epidermal growth factor receptor activation. Oral secretagogues which are used are pilocarpine and cevimelin. People with Sjogren's syndrome have autoantibodies that bind to muscarinic acetylcholine receptors in the exocrine glands. Pilocarpine and cevimelin are muscarinic acetylcholine receptor agonists which help in tear secretion. Anti-inflammatory therapy, we can use glucocorticoids, sex steroids and non-steroidal immunomodulators. Topical glucocorticoids, it inhibits all the levels of inflammation. It is useful in neural pain modulation. Dry eye induced loss of conjunctival gallbladder cells was reversed, but there is side effect of ocular hypertension, cataract and opportunistic infections. Sex steroids, hormones change the homeostasis of the ocular surface. Androgens impact on the structure and function of meibomian and lacrimal gland. It is ongoing research, it is not yet into clinical practice. Non-steroidal immunomodulators, cyclosporin A, it inactivates T cells, inhibits release of inflammatory cytokines. This is FDA approved in 2003 for use in dry eye disease. Tacrolimus is a macrolide produced by streptomyces. It likes cyclosporin, it blocks T cell lymphocyte activity. Its immunosuppressive potential is higher than that of cyclosporin. Lifitegrast is a lymphocyte function associated antigen antagonist. It was FDA approved in 2016 for dry eye disease. Now there are various newer therapeutics like lubricin, recombinant human nerve growth factor, tumor necrosis factor alpha stimulator gene, anti-tumor necrosis factor A, interleukin-1 receptor antagonist, neuropeptides. All these are under research for use in dry eye disease. So basically we have to categorize the patient and we have to give a stepwise treatment to the dry eye. In step 1 we basically do education and dietary modification and give conservative management. We use non-preserved ocular lubricants in step 2. We give overnight treatment and we add topical drugs like antibiotic, corticosteroids, immunomodulators. In step 3 we add on oral secretagogues. In step 4 we add topical corticosteroids for longer duration. We can try surgical punctal occlusion or other therapies like tarsography to conserve the tears. So this is article published by Narayanitkarya. This is the dry eye disease. It's categorized on various severity, and based on the type of management also varies. We can go through this article, and algorithmic approach to the management of post-refractive surgery dry eye is given. Now, tear-film oriented therapy can be given. If there is lipid deficiency, we can use lipid supplementation, warm compress and lid hygiene. In aqueous deficiency, we can give artificial tears, sodium hyaluronate, secretagogues of aqueous secretagogues can be given. If there is epithelial abnormality, we can give secretagogues with autologous serum. And for all ocular inflammation, we can use cyclosporin or steroids. So the nature is changing, so is ocular therapeutics changing in